You're listening to the Veterinary Innovation Podcast.
You're listening to the Veterinary Innovation Podcast. My name is Shawn Wilkie, and along with my awesome co-host, we interview the innovators in this space every week. Ivan, please go ahead and get us started today.
Hi, I'm Ivan Zach. I'm really excited about our guest today. So our guest is Dr. Beth Davidow. And Beth blogs on the issues surrounding ownership, quality, sustainability, and community in veterinary medicine as the Veterinary Idealist. She is a diplomate of College of Veterinary Emergency and Critical Care and has a certificate in patient safety and quality from the Institute of Healthcare Improvement. She previously co-owned 2 multi-specialty hospitals and a blood bank in Seattle. She's now an assistant professor at Washington State University. Beth, what a pleasure to have you here. Thank you for finding the time.
Yes, thank you so much for having me.
So I have a pleasure of talking to you 2 days in a row, which is great. We had you on a webinar, and that was sort of related to this topic. The topic that we want to talk about today is sort of the quality of medicine and the patient's safety, and your experience in that domain. But I think it would be interesting for us to understand. So, as a critical care specialist, I mean, that's such a hard specialization, and it's sort of one of those that I dreamed about but never accomplished. So I'm constantly jealous of people that did that, but I switched sort of into business domain. So because it's so hard, vet school is hard on its own, and then you choose this path to become a specialist, and then you become a business owner. So what does that journey look like, and how was the decision making along your career to kind of pivot in certain directions?
Yeah, so I pivoted a whole lot of times. I actually thought I was going to be a mixed animal practitioner, ended up through various paths, ending up sort of falling into an emergency practice and then discovering that I'm truly an adrenaline junkie. And being an adrenaline junkie means emergency critical care is a really good fit for me because things happen fast, things are sort of scary, and so it sort of feeds that. I ended up being a practice owner basically by accident. Had a case that didn't go well, a tetanus dog. When we were only after hours, there was no 24-hour hospital in the city of Seattle, and nobody else was sort of doing what I thought we needed. And so when nobody else does something, sometimes you have to jump in and do it yourself. So that's sort of what led into practice ownership. Didn't have an MBA, didn't know any finance, had one econ class in college, and you just sort of do it because it seems right to the patients. And then one of the things you realize as you do emergency critical care and as you own a practice is that the things that make you the most crazy is when things go wrong with pets. And so over the course of my career, I've gotten more and more interested in the idea of how do we make medicine better for pets and what is the highest quality care that we can provide. And you realize that sometimes I believe that highest quality care isn't the most state of the art care, but it's when you can produce reliable, consistent, ever improving results and outcomes for pets. And so now that I'm at the university, one of my research interests is really around how do we use quality improvement science? How do we use what we've learned in human medicine around medical errors and understanding mistakes to try to improve veterinary medicine and decrease errors that we're making? So it's been sort of a funny path, but some of it was, you get tired of talking to owners on the phone about things that go wrong. And so you're like, I really don't want that to happen again. And so how do you make that not happen again has become my interest.
No, absolutely. Yeah, and I can really relate to the adrenaline junkie because my passion was critical care. So I was in I was the night guy, the ER
Mhm.
vet. Through my whole career, I've done sort of locum and ER, and yeah, so that was definitely it. But also being an entrepreneur, that's another level of adrenaline
Yes.
junkie. Owning a business, having kids along the way. We talked about that, right? So all of that, and how can I take more on myself? and then try not to burn out, which is what happened to me. So on that topic, how is the burnout related? Because we talked sort of about the talking points, and one of them was that the patient outcomes also lead to burnout. And do you think that this is, because I'm in a sort of constant search of how can we eliminate burnout in the profession? So do you think it's a big component of actually clinical outcomes and the quality of medicine that can decrease that anxiety of veterinarian, that responsibility, and how much that plays role in the entire, sort of our industry problem with the burnout?
Yeah, I think actually burnout and medical errors in patient quality are really linked. And there's actually some really interesting things that are being done through the Institutes for Healthcare Improvement, which is a human medical group that's really trying to improve medicine. And they did some research a couple of years ago and published it as a white paper that's called the Joy in Work White Paper. And one of the things that Don Berwick, who is the former president of this group, Anna MD, talks about is that medicine, and I would say veterinary medicine, are simply noble professions, and that we should, when we do our job, be joyful about how much we're contributing. And yet, burnout is rampant both in medical systems and in veterinary systems. And I think a lot of it is frustration about not being able to provide the care we want to for our patients. And so, what the Joy in Work white paper ended up doing is they did quite a bit of research and they realized that there can be a stepwise process for both improving the way people feel about their jobs, which at the same time actually improves quality outcomes for patients. And so it actually starts with asking everybody who works in your practice what matters to you. And one of the things they found is that when managers and owners ask that question, what matters to you? What do you want to do? What do you want to spend more of your time on? And really listen to that, that people are much more engaged just from the very beginning. The second question you ask is, what are the pebbles in your shoes? And what you realize is that a lot of burnout and a lot of frustration is from little nibbling things that take you so much time every day that just make you crazy that you feel like you can't fix. And I think we underestimate how much of quality improves when you fix the little things, and also how much burnout goes away when those things that cause little mistakes all the time also get fixed. And so you then ask, what are the pebbles in your shoes? And then you systematically go through and fix those. And what you can show in studies is that in organizations that have cultures in which those questions are being asked and system-wide solutions are being implemented, that you actually have lower levels of burnout and higher patient quality outcomes. So really interesting work that has not really been fully brought into the veterinary space at this point yet. But I think really an area that could be researched and really looked at for how do we make our practices better.
Beth, it's really fascinating. And so, the focus of our podcast is around innovation. And I couldn't help but kind of double click on that first question, which is what matters to you. And I think that that's really what also drives innovation, whether it's in veterinary medicine or in software development or wherever, is knowing what a particular individual team member is passionate about. And then if an opportunity for that passion arises, giving the team member the ability to kind of go down that hole. And maybe it's somebody else's pebble. And so I think that those are two very simple questions. Have you seen any practical implications of those two questions kind of through your work that you could kind of point to? And obviously, we'll link the white paper in the show notes because it seems like it would be fascinating.
Yeah, I mean, I guess one of the things that I have found is that as I've started to talk to people about what matters to you and then also what are the pebbles, is that, the pebbles are the things that are the mistakes that are getting made over and over again. And as you slowly start to look at those and taking a really systematic look, you can get rid of some problems. Some of it is, people will get really frustrated by their software, and I think we can improve the time it takes to write your medical records. I think you can improve the time it takes to discharge a patient. When you slowly look at what are the problems in my software and trying to fix those by using canned discharge instructions that are standardized, by using order bundles. I think order bundles can really standardize care. And one of the things we know from human medicine is that standardization that is locally driven and evidence based does improve outcomes. And so if you can then, like, let's say you have somebody in your practice who loves software, and I've seen this in a couple of practices where somebody's like, I can make this work better for us. You give them 5 hours, a week, and they make everybody else go faster because that mattered to them. It's a pebble in everybody's shoe that their discharges take too long. You give somebody the time to optimize a process, and everybody's happier in the practice.
That's amazing. You just, you touched on so many areas that this is like last probably 15 years of my career. And the smart flow was born out of frustration. Because when I'm writing the records and I have to run back and look for the chart when I take three of them, I have an agreement with technicians that I can take only two because they're doing the treatments. Like, that was the point of frustration. That was not a pebble. That was a huge rock in my shoe.
Right.
So that's where they came from, an innovation. And Shawn, I appreciate that you kind of weaved it into the whole innovation point. I love this. I'm going to steal from you the pebble thing, because this is exactly what it is when we talk about continuous improvement. And as I work in consolidation now, or with consolidators, I always was talking about the culture of continuous improvement, and that's what it is about. It's really allowing people to improve little things in their work and continuously appreciate that. And then people are happy because they recognize a problem, B, they feel empowered to fix it, and C, they own the solution. Not only they will own it and do it, they will reinforce it on their peers. It's not an SOP, it's a peer driven processes that are now coming from bottom up. And what I constantly talk about, like, what is it, continuous improvement? There's a lot of lip service in the companies. We are a culture of innovation and continuous improvement. What is that process in your organization where, when there's a problem arises, it goes up through all the layers of organization? It could be fixed locally, but then if you can look at many locations, let's say if you are a group, how do you fix it systemically across of all your hospitals? And I've seen an example of that, and I kind of give this example before about the Boston General Hospital, where they had this sign near the washroom that says, "Do not void before you see a doctor." And because they wanted urine samples, right? And they
Right.
constantly were losing urine samples because people will go and pee. And they
Yeah.
had this Hispanic nurse that was not first language. She said, "Can we change that sign to 'Do not pee'? Because not everybody understands what
Right. Yeah.
that means." And then that was her sign. She owned it, and they changed it,
Right.
and everybody was saving the samples for the doctors. Little thing, she loved it.
Right.
Like, that's such an accomplishment with
Yeah.
very little investment into it, but it bonds the people, and it makes them happy at work. So I'm totally with you on that. So are there things that we can put in sort of a practical perspective because when you're finding research, can you turn it now and say, okay, this is how we should apply it? Or is it a sort of the management work with the clinics, or is there any sort of tricks that you can suggest organizations to implement to kind of follow this path?
Yeah, I mean, I think there's a couple of things. One is that there is one other interesting thing is there was a study done looking at, patient care outcomes. And so the study looked at where were the best outcomes for people who had heart attacks. And, they actually track outcomes for heart attacks in human medicine, and they could look at the top performing hospitals and the bottom performing hospitals. And you would think it would have to do with where did your doctors graduate from school? How good is your surgery facility? What are what kind of money comes in? And they found it was all organizational culture. And so that organizational cultures that had good interdepartmental communication, had psychological safety, so the ability for anybody to speak up, and had this like just targeted goal of improving their care, did better than hospitals that didn't. And that was the difference between quality. And so I
Crazy.
think the very first thing you have to do is to say, we want to hear all voices and really actually hear all voices. That's the number one thing, both for, I think, decreasing burnout and also improving care in hospitals, is that concept of psychological safety. So the first time somebody brings something up and you say, well, that's a stupid idea, then nobody else is going to say anything, right? And so every time you say, that's really interesting, let's talk more about that, the more engagement you have, the more interesting ideas you get, and the more chance you have of innovating in your practice.
And that psychological safety goes through the roof, which I think is the most valuable piece. It's really interesting. I was having a conversation just yesterday along the exact same lines. And what I'd like to draw a parallel to is kind of how we got here. If we look back at the Industrial Revolution and people being in factories and Henry Ford not wanting your brain, but wanting your hands, this is the history of work. The history of work is show up, do what I tell you, don't talk to me, and the faster you can do it, the better. And so we've got this heritage that doesn't work anymore. It just doesn't work anymore. The best performing companies are the ones where anybody is able to be heard and people are able to lean into what they're best at. And so it's really interesting. And I think COVID's been a very interesting time for us to kind of double click on these things and just kind of realize that, the old ways are not necessarily gonna fix today's problems because we've already tried that.
Mhm. Yeah, I think one of my favorite stories is actually the story about 3M and the sticky note. And, 3M had this policy where, this idea of what matters to you and allowing people to work on things they're passionate about. 3M basically said 15% of all your work time should be on something you think is really cool. And actually, the sticky note was developed in that free time. It was not a company objective, it was not something that was being driven. And it's now, sticky notes are used ubiquitously, huge seller that's out there. And it does sort of show that the power of innovation comes from this idea of taking people who have skill sets you don't know about and somehow giving them some period of time to work on or improve those things that are there. And so I think, it's hard to do that in veterinary practices, especially when you're short staffed. But I think if you can find even some time to allow people who say, I have a good idea and I'd like to try it out, to say, let's give that a go, that you are very likely to find things that'll be really interesting, probably make you more profitable, reduce your turnover, and also improve patient outcomes.
And don't forget burnout. Burnout
Right.
Yeah.
probably goes away a little
Exactly.
bit too.
Yeah. Yeah.
Yeah, no, absolutely, and this is interesting. I'm going through finishing actually the design thinking part of the I'm in the lead program at Stanford,
Hmm.
and there's sort of innovation part, and then there's a leadership part, and they are so close to each other. So from the innovation part, I'm just finishing the design thinking course, and that's a huge part in both actually strategy and when you're coming up with the ideas is to have the divergent part of brainstorm. So when you have all the ideas, stupid, non-stupid, when you have the bucket of ideas and everybody is comfortable giving ideas, and then they help people to accept or remove them in the convergent stage. So divergent, you get lots of ideas. This is why also inclusion and diversity is so important, because you get all the ideas from all kinds of angles that you couldn't think of yourself. And then once you get all of those ideas in the bucket, you need mechanism of filtering as well that doesn't scare people, that you just go, okay, this is stupid, non-stupid, stupid, non-stupid. You can't do that.
Right.
So you really need to go through sort of, when people are asking, it was very interesting course. They were talking about working through people that provided ideas and tell them what has to happen for this idea to work. So they help people to build a logic around their proposal and not really dismiss it, but allow people to work through what has to happen for this idea to work. And then they say, a couple of things that are sort of out of this world, and they're like, yeah, that's probably not a good idea. So they kind of, they cancel ideas themselves rather than the top management goes and, shreds half of them. So I think that's very important as well in that perspective. But I was listening to you about because sometimes when people say about the quality of medicine and standardization, they think that, oh, you kind of want to have sort of a cookbook for every condition, and medicine is so complicated, it's so diverse, which after certain years of practices, it is and it isn't, because certain cases are very similar. So what's your take on, as a specialist in the critical care domain, some standardization is good for quality outcomes, or where do you sit on that sort of, people that will say, well, every patient is different, and is it or it isn't, and can we standardize some things because it's a good practice?
So I'm actually a huge believer in checklists, pathways, order bundles,
Awesome.
because I think that medicine is really complicated. And this idea that we can be just artists and we don't need to have checklists is completely wrong. Like, you cannot keep all the information about everything that might walk into your hospital in your brain at one time. And so you've got to have help to be able to make decisions quickly. And so, what I think is that checklists and bundles provide a minimum level of care, and they allow you to disseminate evidence quicker if your bundles and your pathways are evidence based and reviewed on a regular basis. So, in my previous hospital, we as a team actually developed medical protocols that we agreed as a team we would follow. And what we did is we reviewed the literature, we actually wrote them down, we provided the prognosis that we could all give to clients, we were quoting the same numbers based on publications. So they were
That's
all
amazing.
evidence based. And then we had certain set things that we agreed as a team we would always do. Now, what this allowed us to do is that we were actually able to study our outcomes with urethral obstruction over time with certain changes we were making to our protocol over time, because all of the ER doctors on our team had agreed we were going to treat these cases the same way.
That's so cool.
Yeah, so we actually published our results on 192 cats, doing one protocol one way, making a decision at a certain point to change it, and we could show that our changes made a difference in terms of reobstruction rates on those cats. And so, one really big mantra on quality improvement is you have to have a baseline. You cannot tell if you're getting better or not if you don't measure your baseline. And then, if we really want to do good studies about outcomes in veterinary medicine, we have to agree to treat some things the same way, because otherwise the studies aren't really relevant. And so, you know, not everybody's going to agree to do things my way, but if we as a team develop a protocol that we all agree to treat, we're much more likely to do it. Now, those protocols need to be locally based on your local diseases. And you can't develop a protocol in 2010 and still be using it in 2021 because evidence changes. And so they have to be reviewed, they've got to be done. But there's now lots of good studies on the human side showing, for example, every ER doctor, human who finishes is going to have a surviving sepsis card that they're handed as a medical student, which is the bundle that you need to do when a patient walks in your door that you think has sepsis. 6-point checklist, that's what's going to happen. And just drilling that into your brain, those 6 points, is a much better way to make sure it happens than just teaching everybody what's in a textbook. You need simple things in ways that are kind of pockets of information for people to actually do the right thing.
It's like for podcasts, we need a checklist for Sean to click record because we actually forgot to record two of them.
Oh, yeah.
Yeah, I mean, I could have the checklist and then I could remind you to do your job because after all, it
Yeah.
is your job to mess
It
them up.
was my job.
Yeah.
So, Beth, it was absolutely awesome and so much fun. We kind of ran out of time like way, way, way
Yep.
quick. So thanks for joining us. A couple things before we wrap up here. You had mentioned your blog. How do people find you online if they want to kind of follow you? I know I'm gonna subscribe or follow you because the
Yep.
conversation was so much fun.
Yeah. So I'm blogging at vetidealist.com, and there's a lot of blogs and conversation there, and you can reach me through the blog.
We'll make sure to link it in the show notes. And we end every episode the same way. So the first question is a book, a TED Talk, something that's inspired you. It sounds like maybe this white paper, but maybe something else. We're going to link the
Yeah.
white paper. So feel free to give us something else as well.
Yeah, so one of my favorite books is called Radical Candor, and it's by Kim Scott. And she's actually going to be one of the speakers at the AVMA Economic Conference this year.
Really? Oh my
Yeah,
God, I
she
love
is.
her.
Yeah.
I
Yeah,
love
so
her.
she's great. So she is a leadership consultant who's worked for a lot of tech companies, but really has some great strategies about communication and feedback within practices. So great book.
They love the book. We actually implemented in our company all of her practices, and we had the company-wide training on providing feedback based on that as well. And I think it's a huge problem in veterinary medicine, because as soon as they join a big organization after acquisition, I think they need to go through conflict resolution
Yep.
training and feedback training. Those are the two things that people don't do enough.
Yep.
And so I really appreciate that recommendation. We also ask about someone interesting that you would recommend to invite to this podcast, if you can think of anybody.
Yeah, I would recommend having Dr. Katrina Maley on the show. So she runs the program for individualized medicine at Washington State University. And she was one of the researchers who identified the MDR1 mutation in dogs, which influences how they metabolize drugs. And I certainly think one of the things that has happened in human medicine is this idea that people are different in how they deal with drugs. And so our care that we provide needs to be very tailored based on genetics. And she's the one who's doing that work in dogs right now. So super interesting, innovative things that are likely going to be changing the way we provide therapy to animals in the future.
Thank you so much for listening to the Veterinary Innovation Podcast. If you want to hear about our new episodes, please follow us on any social media channel. Also, you can check out our website at veterinaryinnovationpodcast.com. See you next week.